Welcome all. I'm Dr. Charlie Roberts. I'm Cancer Center Director here at St. Jude Children's Research Hospital, and along with Dr. Charles Mulligan, co-host our weekly series on the science of childhood cancer. So it's a real pleasure to have Doug Hawkins here today. And so as I introduced Dr. Hawkins, given that we have an international audience that includes early trainees as well as professors and department chairs, I think it's important to mention the impact of the Children's Oncology Group, of which Dr. Hawkins is group chair. So COG, or Children's Oncology Group, is a National Cancer Institute-supported clinical trials group that is devoted exclusively to childhood and adolescent cancer research. COG member institutions include more than 200 hospitals, universities, and cancer centers that are principally in North America, but also international, including Australia, New Zealand, and Europe. And I really think of the importance of COG, given the rarity of childhood cancers, and increasingly as we're learning that many cancer types are driven in subtypes by distinct genetic mutations. Collaborations between many centers brings incredible strength by amplifying the power and facilitating the speed with which new therapies can be tested. And so COG, by bringing together over 200 centers and having nearly 100 active clinical trials at any one time, is really key and central to advancing the field. And so it's for this, amongst other reasons, that I felt that inviting Dr. Hawkins to speak is ideal for a series on the science of childhood cancer. So briefly about Doug, as I mentioned, he is group chair of COG. He's a clinician at Seattle Children's Hospital and professor of pediatrics at the University of Washington School of Medicine. Prior to becoming the COG group chair in 2020, he was chair of the COG Soft Tissue Sarcoma Committee, overseeing the conduct of biology studies and clinical trials for rhabdomyosarcoma and other soft tissue sarcomas across North America. He was member of the COG Bone Tumor Steering Committee, and he's focused principally on clinical research in the treatment of pediatric sarcomas. He's the chair of 2 COG clinical trials, one for Ewing sarcoma and another for rhabdomyosarcoma. He chairs the International Euro-Ewing Consortium External Advisory Board and also the International Frontline Relapse Rhabdomyosarcoma Study Data Monitoring Committee. And so just before I throw to Doug, I'd like to mention our next 2 upcoming talks. Next week is David Jones from the German Cancer Research Center, DKFZ, who's going to be talking about pediatric high-grade glioma, novel drivers to find a tumor spectrum subgroups. And the week after that is Dr. Karen Vousden from the Francis Crick Institute in the UK, who's going to be talking about a role for metabolism in cancer development and progression. And with that, I'd like to throw it to Doug.
All right. Thank you very much, Charlie, for the kind invitation to speak. I may be one of the least scientific speakers at this symposium. I looked over the prior speakers, and it's a very impressive lineup. But I hope to share with you my perspective, as Charlie alluded to, on the impact of the Children's Oncology Group and how it can play a role in advancing the state of knowledge and the outcomes for children with pediatric cancer. I have no disclosures in the past year to report. These are the topics I hope to cover today, including the overall role that COG has played in the past and in the future in pediatric cancer research. I'm going to spend a fair amount of time discussing specifically the potential for molecular profiling and sequencing to guide treatment and some of the barriers to implementation, as well as to discuss some of the barriers to new agent development in pediatric oncology. I thought I could start with some of the facts. Pediatric cancer is rare. Based on data from the American Cancer Society, there are nearly almost 2 million adults in the United States diagnosed every year with cancer. Compare that to less than 16,000 children in the United States, less than 20 years of age. So pediatric cancer compared to cancer in adults is quite rare. Nonetheless, it is a significant public health issue. It's the leading cause of death from disease in children in the United States. And in the United States, we estimate that by the time someone turns 20, they have 1 in 285 will develop cancer. So this remains a major public health issue, even though it's much less common in children than it is in adults. This is also data from the American Cancer Society comparing the types of cancers seen in adults. We know this well. The cancers in adults are typically carcinomas or diseases of the aerodigestive tract, more typically seen in adults, both men and women. Contrast that to the types of cancer we see in children. There are some large groups such as ALL and CNS, all the CNS tumors grouped together. But in general, pediatric cancers are really a collection of rare and ultra-rare diseases, which in aggregate add up to the nearly 16,000 cases seen in the United States every year. So this poses a major challenge to clinical trial development. As Charlie alluded to, pediatric cancer is rare, so how do we design trials? How do we learn from tumors that are very rare? Well, the only way you can do that is through collaboration. And I'll try to make that point throughout my time today. I think collaboration is really what led to some of the most dramatic improvements in childhood cancer survival that was seen. And I'll now show you data again from the United States. You can see that in the 1950s, there was a fixed mortality rate per 100,000 children less than 15 years of age. This is prior to systemic chemotherapy being available. During the 50s, 60s, and 70s, the National Cancer Institute funded a variety of cooperative groups that were focused on developing treatment for pediatric cancer. And coincident with the formation of those groups, we saw the mortality rate from childhood cancer drop dramatically. Now, I can't prove to you that it was these cooperative groups that led to this improvement in childhood cancer survival, but the whole reason these groups were formed was to develop treatments to reduce the mortality rate from childhood cancer. So I think they are directly causally related to the improvement in overall survival. In 2000, the Children's Oncology Group formed from the merger of the 4 preceding cooperative groups, and we've seen continued improvement in mortality rates since that time. I'll show you updated data in a few slides. Now, I want to reflect on that era where we saw these dramatic improvements in pediatric cancer survival rates, the 70s to 2000. The typical pattern of trials done in CCG and POG was that one regimen with multiple different chemotherapies was compared to another regimen with some changes in dose and schedule of those drugs, maybe an additional drug added. One regimen was identified as a winner. This was brought forward to the next clinical trial. These trials typically involved hundreds or thousands of patients. A similar comparison, maybe with a change in schedule or dose or the addition of a new chemotherapy. A winner was identified, and so on. Sometimes the prior winning regimen was still the winner, and the new regimen was not superior. But this was an iterative process, and for the most part, this was driven by empiricism. In fact, it's worth noting that during this 30-year period of time, not a single immunotherapy or targeted therapy was incorporated into the treatment for childhood cancer, yet we saw these dramatic improvements in survival for pediatric cancer, despite the availability of agents that we're very excited about in 2021. I'm now going to illustrate that more specifically with the case of acute lymphoblastic leukemia, or ALL, the most common type of cancer in children. This shows the success story that many of us are so proud of, looking at cooperative group studies, comparing the survival for childhood ALL in the late 60s and early 70s, where there were survivors, but relatively few, and then this dramatic improvement in the 70s and continued in every 5-year increment to see improvements in overall survival from childhood ALL. Now, this occurred despite the fact that we were basically using the same drugs that had been developed for a long time. In fact, this is a list of the most common agents used for treatment of ALL and the years in which they were approved by the FDA. I will note that many of these drugs were approved by the FDA before I was born. In fact, this is particularly pertinent to me today because today is my birthday. I was born in 1964, so I am as old as vincristine was approved by the FDA. And yet these drugs, which had been available for a long time and are standard cytotoxic agents, were by altering schedule, dose, and or sequencing, led to improvements in the outcome for childhood leukemia. So this is another way to look at the overall survival rate for all types of pediatric cancer, looking at survival rates by 1, 2, 3, 5, and 10-year increments using SEER data. And you can see that as across the age that SEER data have been monitored, we can see improvements in these landmark survival rates over time. And pediatric oncologists are typically very proud to say that now a child diagnosed with cancer has a better than 80% chance of surviving for 5 years. And that is true based on the data that we've seen from SEER. But I would argue that that may not be the goal we should be trying to achieve. First of all, this 5-year survival rate belies the heterogeneity of outcome within pediatric cancer. These are now the same SEER data broken up by individual histologies, and we can see that for certain tumors, Hodgkin lymphoma, that's the bars on the right within the red box, the survival rate approaches 100% in all age groups. Contrast that to AML, where the survival rate is not nearly as good, in the range of 60%. But even within the single disease like ALL, where if you're less than 15 years of age when diagnosed, the survival rate is over 90%, the survival rate for teenagers or older teenagers is worse. So even within the same disease, just using clinical features, we can identify populations that have a worse outcome. So what this says is that the 5-year survival rate overall is really not the measure we should be looking at. We should also focus on diseases for which outcome remains inadequate. But we are proud of the story of childhood survivors. Successful treatment of childhood cancer has led to an increased number of survivors worldwide and in the United States. In fact, we estimate in the U.S. today about 1 in 750 people in the United States is a survivor of pediatric cancer. And that by last year, there were approximately 500,000 childhood cancer survivors in the United States. And that's an incredible achievement given where we were 50 years ago. But I think that is only part of the story. And these are data from the Childhood Cancer Survivor Study, or CCSS, where to be eligible for the study, one had to have childhood cancer and survive for 5 years. So the axis starts at 5 years since diagnosis. And you can see in the blue line that even among 5-year cancer survivors, there are children who are now childhood cancer survivors into adulthood who are dying of their original cancer. And that continues to go up 10, 15, 20 years later. And the yellow curve shows the deaths not from the original cancer, but from complications of the cancer treatment. In other words, a child who survives for 5 years can still die from their original cancer or die from complications of their treatment, despite having survived for 5 years. Now let's look at this data in a little bit more detail from CCSS. This shows the cumulative incidence of different toxicities graded 1 through 5 by severity. You can see that by 30 years after a diagnosis of childhood cancer, these childhood cancer survivors have a more than 70% chance of having any toxicity. And if you just look at the severe, life-threatening, or fatal toxicities, nearly 40% of long-term cancer survivors will have severe, life-threatening, or fatal toxicities. Now, this may have improved a little bit over time. These are data that Greg Armstrong recently published in the New England Journal of Medicine, looking at different era of studies within the CCSS cohorts, showing that the mortality rate from treatment-related complications has reduced in more recent cohorts. But I still think we have room to improve the outcome and reducing the risk of fatal toxicities from childhood cancer treatment. So I'm going to show you a series of slides that describe what I think are summaries of what our successes are and what some of the challenges. And I'll start with survival. It is truly a success story that greater than 80% of children diagnosed with cancer can expect to survive for at least 5 years. That is a dramatic improvement. However, as I've shown you, 5-year survival is not the same thing as long-term survival. And there continue to be cohorts or subgroups of pediatric cancer for which the survival remains inadequately low. And for many cancer survivors, survival comes at a cost, including severe late effects. So I have 2 questions to pose to you. The first is, for a child with cancer, survival for only 5 years after diagnosis, is that an acceptable goal? And second, for a child who does survive childhood cancer, are severe life-threatening complications acceptable as the trade-off for having survived the original cancer? I think if you say no to either one of those, or to both, then you share the mission of the Children's Oncology Group, and St. Jude for that matter, that our goal should be restoring a child to lifelong health with the minimal to no long-term side effects of treatment. And that is the underlying mission of the Children's Oncology Group, which, as I mentioned, was formed in 2000 by the merger of 4 legacy pediatric oncology groups. It is the NCI-funded cooperative group for pediatrics. There are 4 other adult groups in the United States. As Charlie mentioned, there's over 220 institutions. The majority of those are located in the United States, but there also are institutions in Canada, Australia, New Zealand, and Saudi Arabia. We have over 8,000 members, and we estimate that approximately 90% of children with cancer in the United States are treated at a COG institution. The membership of COG is quite diverse, and this shows you a pie chart of the different members. We have a large representation from nursing and hematology oncology practitioners, but we also have our research associates, pharmacists, and then a diversity of other specialists, physicians or other specialists who provide the various components of care and are necessary for the research mission of the Children's Oncology Group. The COG is organized around scientific committees. I am the group chair, Leah Gore is the vice chair. We have 12 different disease committees that are organized around the major different types of pediatric cancer. And they design most of the clinical trials that are run by COG. They work collaboratively with domain and discipline committees that sometimes run their own studies, but also are able to interface, providing some of the other expertise that is necessary for the disease committees in order to run our clinical and biologic studies. COG is a broad-based geographic organization. This is a map of sites of COG institutions just within the United States. And I think this can demonstrate the geographic reach of a group like COG, where regardless of where children are located in the United States, there are COG sites, institutions that are nearby them. And as Shirley mentioned, this is an international organization. We have sites in Australia, New Zealand, and Saudi Arabia. We cut off New Zealand in this map, but we need to add them in there. But it is truly an international group, although it's dominated by North American participants. Now I'm going to go back to talk about the improvements in the COG era. Now, this is a different way of looking at outcome for childhood cancer, broken down by leukemias and lymphomas in green and the lower curve, and all other cancers in blue. You can see that there was dramatic improvement in the 70s, 80s, and early part of the 90s, but in the late 90s, the second half of the 90s, there was a bit of a plateau, both of the leukemia lymphoma overall survival change and in other solid tumors. That was the time where COG was formed, and there was a lot of concern that perhaps the cooperative group network, which had served us so well in the 70s and 80s, was no longer going to pay the benefits with our clinical trials, that we had seen that whatever benefit we would get from clinical trial research would not be borne out with future research. But it turned out not to be true. After the formation of the COG, we could see that there was then continued improvement in overall outcome survival, both for leukemia, lymphoma, and other cancers. So I think the benefits of cooperative group research has continued to be seen even in the more recent era. Now, where are these patients from COG coming from? COG is very good at enrolling children, younger children on our studies. And this is from a recent analysis from COG data compared to SEER registry data for U.S. populations from 2003 to 2015. And you can see that if you're less than 10 years of age, over 25 to 30% of children will enroll on a frontline COG study. That number decreases in the teen years and becomes very low in young adults. I will say that the participation in COG studies compared to the estimated number of cases based on SEER data seems to be relatively balanced across racial and ethnic groups, with the exception of Native Americans and Native Alaskans. But comparing COG enrollments on frontline studies to the SEER incidence data, we can see that the populations are relatively balanced by race and ethnicity. In the younger patients, 0 to 9, the same is seen in 10 to 19 years of age. Now, why is COG able to do this? Well, I think it's because of this geographic reach. We have a variety of sites, some of which are very small, some are medium-sized, and some of which are very large. This is a histogram of total enrollments on COG phase 3 or pilot studies in a 3-year period of time, with each column being one institution, and they're given in rank order from lowest accruing institution on the far left and highest accruing on the far right. And you can see that there's a wide range of total enrollments during this 3-year period of time. But if you look at this in aggregate, if you want to look at half of all the enrollments on our phase 3 and pilot studies, they came from the largest 42 institutions within COG. But if you wanted to get the remaining 50% of the enrollments, you needed the aggregate effort of 187 institutions that were small and medium sized. In other words, in order to run these large phase 3 studies, we need not only the efforts of the large institutions, but we also need the cumulative effort of all these small and medium sized institutions in order to make our accrual targets work. Now, I'm going to talk a little bit about clinical trials, and I'm going to use an example of a trial recently published from the St. Jude Consortium in medulloblastoma and compare it to 2 studies run in the Children's Oncology Group around the same time. And I'd make this comparison not as a way of criticism, but to illustrate what can be done with focus efforts within a limited institution consortium and what can be done within the COG consortium. So this study was just published this last month by the St. Jude Consortium. It enrolled children with both average and high-risk medulloblastoma. Treatment was roughly the same with some differences in radiation for the two different risk groups. But what was the strength of the study was that biology material was collected and then analyzed. And using the strengths of the St. Jude to analyze, to molecularly characterize these tumors in a context of uniformly treated prospective clinical trial, you could see that the groups, the subgroups of medulloblastoma, as defined by investigators at St. Jude, could be identified. They segregated as predicted. The methylation profile was also able to distinguish the different groups, and the outcome was differential based on the four different groups. But perhaps more importantly, again, because of the strength of the incorporation of biology into the study and the uniform treatment, the risk grouping could be further refined by doing additional exploratory biology, could identify within subgroups, such as the sonic hedgehog subgroup in the upper right panel, you could identify risk groups, you could subdivide risk groups into a very positive, favorable group and a less favorable group. So again, I think this shows the strength of what can be achieved with a small consortium, with a uniform treatment, and emphasis on the biology to further refine risk stratification. Now, contrast that to what COG did in roughly the same period of time, and I will say, with including some of the very same investigators on the St. Jude consortium study, as well as the COG study, including the people doing the biology. There were two studies done by the Children's Oncology Group, one in average risk. The study enrolled twice as many patients as were average risk patients on the St. Jude Consortium study, but there were two randomized questions being asked. Because there were more patients, you could ask randomized questions. I'm not going to focus on the field, the specifics between whole posterior fossa versus involved field radiation, but instead focus on the randomization limited to the younger patients aged 3 to 7, where either a lower dose of radiation was given to the cranial spinal axis versus a standard dose. This study also collected biology specimens. They were analyzed by the St. Jude investigators, and you could see very similar findings. You could segregate patients into the four subgroups of medulloblastoma. They could confirm that the subgroups had differential outcome and that the methylation analysis could also identify the subgroups. But within this analysis, again, I want to focus on the randomization for the cranial spinal dose. If you look at the aggregate population, there was an inferior outcome seen in the patients who received the lower dose of cranial spinal radiation. And so if you simply looked at the entire population, you might conclude that lower dose radiation was inferior. However, because of the strength of the biology of collecting the material and the fact that you had a randomized study, you could examine the randomized intervention differentially within each of the four medulloblastoma subgroups, and you could see that the decrement in outcome was restricted to the group 4 medulloblastomas, whereas the other subgroups had similar outcome regardless of whether they received the higher or the lower dose of radiation. In other words, you could target the need for the higher dose of radiation to the group 4 patients who appeared to benefit from this. So again, this is the strength of a larger population and a randomization. Also coincident at the same time was an analysis done, was a study on high-risk medulloblastoma or PNT. This enrolled nearly 3 times as many patients as the high-risk population in the St. Jude series. There were 2 different randomizations. I won't focus on the retinoic acid because that was dropped early due to futility, but instead look at the randomization to carboplatin given daily during the radiation therapy phase. And you can see that if you look at the aggregate population, there was no benefit to carboplatin, addition of carboplatin compared to no carboplatin with radiation. However, again, the same biologic analysis was done again with the St. Jude collaborators performing the work. And when you analyze the addition of carboplatin within the 4 subgroups, you could see that there was a benefit now in subgroup 3 medulloblastoma with the addition of carboplatin. Now, this is the panel at the lower left, having a benefit in terms of event-free survival with carboplatin, whereas the other groups did not benefit from the addition of carboplatin. So again, this shows the benefit of a large study, randomization, allowing you to address the differential impact of an intervention within a molecularly characterized subgroup, but also demonstrates the strong partnership between COG and St. Jude in performing the biologic analysis. Now, I think this is all well and good, but I think we need to realize that that our participation in clinical trials, pediatric clinical trials, has gone down over time. If you look back into the early 90s, nearly 3/4 of children with cancer enrolled on NCI-sponsored cooperative group clinical trials, and that was in stark contrast to the enrollment rate seen in adults. But in the more recent cohorts, in the early part of the century, and more recently 2004 to 2015, those enrollment rates have dropped down to 20 to 26%. Now, this doesn't tell the whole story because this is only COG cooperative group studies, or the preceding cooperative groups, and doesn't account for enrollments on other consortia, such as sponsored by St. Jude or Dana-Farber or Stanford. But I think in some, they contribute a relatively small number compared to the enrollments on the COG studies. But I think what this says is we're actually not studying most children with cancer within cooperative group studies anymore, not in contrast to what was going on in the early 90s. So another summary of successes and challenges. It is remarkable that COG is able to have so many open studies. Even at the time of COVID, we have over 70 currently enrolling COG clinical trials. We have broad participation across the United States and Canada, as well as in other countries. But the challenges are, we have to recognize that participation in our clinical trials has decreased over time, and designing our clinical studies is becoming quite rare, difficult, and rare patient populations. And I want to go back to that slide I showed you with the enrollments on cooperative group studies by era, and ask you, well, what about this other 80%, the 80% of children who have cancer in the United States, and yet we're not enrolling them on frontline cooperative group studies? How are we going to learn about them? How are we going to, if pediatric cancer is rare, we need to learn from every patient we can see. We need to have the potential to analyze biologic material, contact people for epidemiology research. How are we going to do that if only 20% of children enroll on frontline clinical trials? Well, I think the way COG has tried to approach this is by establishing a biology and registry study called Project Every Child. This leverages the biobank that is located in Columbus, Ohio, where specimens from across the COG network, blood and tumor, can be stored. Since the Project Every Child was formed in 2015, over 24,000 children have enrolled. There's over 100,000 biospecimens that have been collected, many of which have gone out to investigators. But making these specimens valuable is the clinical annotation, both initial features and outcome, that is attached to these biospecimens. We also have permission to contact people for future research, and this has been a boon to our epidemiology research projects. Now, Project Every Child, that title is aspirational. Obviously, every child in the United States is not enrolled on this study, but we estimate that for children in the United States who are less than 14 years of age, about 45% are enrolled on Project Every Child. So that's not every child, but that's a fairly large cohort of children for whom we have biospecimens and we have clinical annotation. I think we can make it better with some improvements. Now, to show you the same data for Project Every Child as I did for the clinical trial enrollments, this is the effort that is dependent on large institutions. 52 institutions contribute half of all the enrollments in Project Every Child, but it's the aggregate effort of 174 other institutions that allow us to reach these accrual goals for Project Every Child. I'm now going to shift gears a little bit and talk about precision medicine, because I think that's obviously something that everyone is very interested in. The idea that a tumor can be from an individual patient can be characterized, that we can find a pattern of alterations that would then identify specific therapies, drug A, that would target that particular pattern that's seen in this particular patient, and that would lead to increased activity and potentially decreased side effects. That's the sort of the short layman's view of what precision cancer medicine is all about. And this is not a new concept. Imatinib, which may be the only chemotherapy to ever make the cover of Time magazine in 2000, was probably the first of these targeted therapies. And this was applied quickly to pediatric cancer. And this is a COG study comparing the outcome for children with Philadelphia chromosome positive or BCR-ABL positive ALL, where in the lower curve, the outcome was quite poor in the area of chemotherapy only. But the addition of imatinib to fairly intensive chemotherapy, the upper curve demonstrated a dramatic improvement in outcome by adding this targeted therapy, imatinib, the inhibitor of the ABL kinase. But I think we need to remember that at least when this was first developed, the percentage of children who had the target for which we could use imatinib was relatively a small percentage of all of B-cell ALL. Now, I recognize that there are pH-positive leukemias that can also be targeted with imatinib or other tyrosine kinases or other alterations that potentially can be inhibited with targeted therapy, but they still represent a relatively small percentage of the entire ALL pie. So it's a wonderful intervention. It really has transformed the treatment for pH-positive and pH-like leukemia. But I think we have to recognize it's still for a relatively small group of children with ALL. Now, the same use of targeted therapy has been identified in solid tumors, and this is a dramatic example of a child who had an infantile fibrosarcoma, which carried a ETB6 and TRAC3 fusion. Fortunately, and this is a child who was identified at birth, had a resection, had regrowth, and was started on treatment with a specific TRAC inhibitor, larotrectinib, at 31 days of age. And the upper left panel shows the baseline image, and then 2 days later, after 4 doses of larotrectinib, 4 doses, 2 days later, you can see a dramatic improvement in the mass that was visible just by photography. And then in the middle panels, you can see the MRI demonstrating the dramatic response to the soft tissue mass. So this is an example of a child who, when we knew they had a specific alteration, we could assign a therapy, a very specific tyrosine kinase inhibitor that has high level of specificity and very low off-target toxicity. Now, we know that it's certainly possible to obtain genomic profiling from children. And this is a beautiful paper that aggregates data from nearly 1,000 pediatric tumors and multiple investigators, most in Germany, but also some investigators at St. Jude and other sites, where the very comprehensive genomic data was aggregated. It was used to identify distinct or molecular subtypes of pediatric cancer, and showed that they were really quite distinct in many ways from cancers in adults. Just as an example, this is looking at mutations per megabase. On the far right are typical adult tumors, and again, the scale, the axis on the y-axis is log. You can see there's many more mutations per megabase in the typical adult cancers compared to the tumors on the left, which are all pediatric tumors, where many of them are quite genomically silent. And using some relatively loose rules about what is actionable, applying those rules to this cohort of nearly 1,000 pediatric tumors, this group assessed that maybe about half of patients, if you did comprehensive genomic analysis, you would identify a targetable lesion. So it certainly is possible technologically in the current era to do this sort of profiling to identify alterations in the vast majority of pediatric cancers and potentially identify therapies that would be uniquely would be targeted to a profile in that particular child's cancer. Now, this has been done not just on a retrospective basis, but also prospectively with a number of studies that have applied a panel of sequencing to a cohort of patients to then identify actionable alterations with the hope of then finding a targeted therapy for them. And this is a summary slide that I received from Julia Glade-Bender of a recently published series from a variety of institutions. And a few things to note. These are, in general, fairly large institutions, although the cohorts of patients studied were relatively small. These are generally patients with recurrent cancer, but the cohort size was relatively small in the 50 to 150 patients series. Now, they all had similar findings in the sense that somewhere between a third and maybe up to 50% of patients applying a panel of sequencing, fairly broad panel of sequencing, you could identify an alteration which is potentially actionable, but only a minority of those patients were able to then go on and receive a targeted therapy. And I'll get to why that was in a few minutes. So the summary, I think, from from this last few slides is that we certainly can do genomic sequencing, but as of today, in 2021, this sort of testing is really limited to selected institutions which have made a commitment to do this testing or have grant funds to do this testing. But unfortunately, many children with cancer in the United States are not treated at those centers, and many insurance coverage does not include broad genomic testing, so that this can't be covered at a commercial or academic vendor. And in some cases, the turnaround time for this genomic testing is just too long to impact care. And perhaps the biggest issue is, even if you could do this in a relatively rapid period of time and do this uniformly for children, identifying a potentially targetable lesion doesn't necessarily guarantee you access to an investigational agent. So the way a number of countries have tried to address this is by developing sequencing panels such that they could offer sequencing regardless of where patients are located in their country, and then attempt to tie the sequencing results to access to medications. And this is just a summary of the various approaches taken in 6 different countries. I'm going to focus on the approach taken in the United States with COG in partnership with the NCI, where in the pediatric match. And with this model, children with recurrent or refractory solid tumors were eligible to send tissue at relapse for a central battery of testing with predefined analytes and potentially matched agents, so that if a child was identified as having a specific alteration, a whole series of alterations, they could then be matched to an agent. And that brings together both the sequencing and access to the agent to make that final link possible. This is a list of the various NCI COG pediatric match studies. There are multiple subprotocols after someone enrolled on the screening study. If they were found to have a match, they could be eligible for one of these agents. And you can see that these cover a broad range of different targets and agents. Many of the studies are still accruing patients, although a couple have either closed or suspended because they've met their accrual goals. But I think this is an example of how we can bring together and make available to any child in the United States, regardless of whether they're at a small, medium, or large institution, sequencing as well as access to these investigational agents. So that addresses the issue through the pediatric match, but it doesn't really address the larger issue of getting access to sequencing at the initial diagnosis for children. And to try to address this, COG and the NCI are entering into a study which is still under development called the Molecular Characterization Project. This will be funded through the Childhood Cancer Data Initiative. And the idea here is that we will identify a population where we think this could be useful: CNS tumors, soft tissue sarcomas, other rare pediatric tumors. We'll leverage Project Everchild to collect tumor tissue, extract nucleic acid, and then send it to a vendor to be determined for relatively rapid DNA, RNA, and methylation analysis, with a rapid return within 3 weeks of receipt of results back to the institution. That way, the institution will have all the information, both to refine the diagnosis, potentially identify a target for which a more specific therapy could be used, and also to potentially inform prognosis. Tissue will be banked for additional research discovery work that may take longer than this 2 to 3 week turnaround time. And all of this information will be annotated with the data that is collected through Project Everchild. So this is still an aspirational hope. We're still in the works of setting up what this is going to look like, but I think this will complete the link of making sequencing data, at least for a selected number of tumors, available to children across the country, regardless of whether they're seen at a small, medium, or large institution. Now, I want to turn a little bit to one of the other observations in all these studies was that about 10% of children who had the sequencing had a finding that potentially was of germline significance. And as you know, at St. Jude, you published a wonderful paper about 5 years ago analyzing a cohort of over 1,000 germline specimens from children with cancer, and found that 8.5% of children had a pathogenic or likely pathogenic variant in their germline, compared to a much lower rate in controls. And that, more importantly, only about 40% of these children had a family history that was documented. In other words, most of them would not have been suspected, just based on family history, of having a cancer predisposition syndrome. And this shows you the distribution of the 21 cancer predisposition genes that were identified in the sequencing effort, with TP53 being the most common. And then there was a different rate of alterations seen among different cancers. But I want to focus on one example, because I think this also points out the strength of a limited project, limited even though it's 1,000 children, versus a larger project that could be done within COG, and that's by focusing on rhabdomyosarcoma, an area of interest of mine. There were 43 children sequenced. There were 3 who had pathogenic or likely pathogenic variants, but that was still only 43 children with rhabdomyosarcoma. Now, COG examined a much larger cohort, over 600 children with rhabdomyosarcoma. We had clinical data available. We found almost the exact same rate of pathogenic or likely pathogenic variants as seen with a smaller cohort from St. Jude. But we also found other genes that were associated with rhabdomyosarcoma that had not been seen in the St. Jude cohort. Again, because it was a larger cohort, we could find genes that were present at a lower frequency. And also, we could look at whether there were other clinical associations with the probability of a germline alteration. So we knew whether patients had alveolar or embryonal rhabdomyosarcoma. The upper panel is embryonal rhabdomyosarcoma. The patients with germline alterations tend to be much younger, mostly those with P3 alterations, than the patients who didn't have a germline variant found. And that's in contrast to tumors, to patients who had alveolar rhabdo. First of all, there was no age predilection, and there was a much lower rate of germline alterations. So again, similar findings at the high level of frequency, but we could do this finer gradation of finding associations of clinical features and germline alterations because the cohort was so much larger. So again, a summary here. One of our successes now is that tumors genomic sequencing is certainly feasible, and these analyses can be used to direct therapy, including identifying predisposition syndromes. But the real challenge is this type of sequencing is simply not available to all children with cancer, mostly due to spotty insurance coverage. And just because you can sequence the tumor doesn't mean you can get access to the targeted agent. I'm now going to talk a little bit about drug development in pediatric cancer, and I am winding up, so we'll be able to get done on time and have some questions. Pediatric, there have been a number of drugs approved by the FDA over the last 20 years, but over 100, but very few of them, only 5%, had children included in the initial approval. So the children were studied much later in the time and got approvals much later, even amongst the drugs that ultimately were approved by the FDA for a cancer indication. So this shows you all the drugs and the incidence of how they've, or the frequency that they have been approved by the FDA. And this really, I think, illustrates the point that there's a delay between when the first in-human studies are started, even for drugs that end up being approved, and when those first-in-child studies happen. And this is analyzing those 110 drugs that were approved by the FDA. And you can see there was a median lag of 6.5 years from when the studies started in adults to when they were started in children. Now, the way COG is trying to approach this is by trying to engage actively with pharma to do studies that can lead to an FDA approval. And these are a variety of drugs that have been approved using COG or legacy COG data for the approval. The FDA used the COG data for the approval. And you can see that the tempo of approval has increased. There are more in the last 10 years than in the preceding 10 years. Most of the drugs have been approved for leukemia or lymphoma indications. But I think this illustrates the fact that COG studies can be used for a regulatory filing and lead to an approval by the FDA. And this is so critical for making these drugs available to children, regardless of where they're seen. This is an example of a COG study that I hope will potentially lead to be used for regulatory filing. This is just published in this month. A study in children with recurrent ALL where there's randomization between after induction therapy to either blinatumomab or chemotherapy, and you can see that there was a dramatic difference in disease-free survival and overall survival. There's also a very dramatic difference in toxicity between the two arms. So again, this is the kind of study that really is practice-changing because it's randomized, because it's a large cohort, and could lead to a change in the label. Now, the COG has taken this finding from the study into the next frontline study, a series of frontline studies. So because blinatumomab had this activity, it is now being tested in a cohort of patients who had standard risk ALL and with a randomization to the addition of blinatumomab. This is just one example of the type of incorporation of immune related therapies in ALL. In high risk, our study is asking the addition of inotuzumab, immunotoxin, to high risk therapy. And perhaps the most speculative of the studies, identifying a very high risk population of children with ALL based on their high levels of MRD at the end of consolidation, who could be candidates for CAR T cell therapy while still in an initial morphologic remission. This is potentially high risk, but also potentially high reward if this incorporation at a very early time point of CAR T cells can change the outcome for this group of patients with a very high risk of recurrence. So again, successes and challenges in pediatric cancer. Targeted therapies are a real possibility for a number of tumors, and that number has increased over time. And immunotherapy is effective, particularly in relapsed ALL. But our challenges are our drug development timeline just remains too slow in pediatric cancer compared to how drugs are being developed, the speed in adults. And I've given you the examples of success of targeted immunotherapy, but those examples are more the exception than the rule. And so I think we still need to see to study whether we can increase the spectrum of tumors that can be treated with targeted immunotherapy. So now I'm going to close with just a few thoughts about the priorities for COG in the future. I would be remiss if I didn't comment about the impact of the COVID pandemic on COG. And this is data showing quarterly enrollments in non-therapeutic studies, that's the blue curve on the top, or therapeutic studies, that's the green curve on the bottom. Starting in 2019 and going into 2020. And you can see that our therapeutic enrollment started to go up when we opened a frontline standard risk ALL study, and then continued to go up when we opened a frontline high risk ALL study. But then the pandemic happened. You can see that at the outset of the pandemic in the second quarter of 2020, we saw a drop in non-therapeutic clinical trial enrollments. This is predominantly Project Every Child that has since rebounded, but not recovered to the 2019 levels. But despite the impact of the pandemic, our enrollments on COG clinical trials, therapeutic studies, in 2020 are running ahead of 2019. Now, there was some week-to-week variation, but looking at the quarterly data, we didn't actually slow down, which is kind of remarkable given the impact of the COVID-19 pandemic on medical practice and research in general. I think this does speak to the commitment of COG investigators to enrolling on clinical trials and to get the studies done. So where should we be focusing our attention in ALL or in COG? I think we need to, we're not going to run phase 2 and phase 3 studies for every disease. We're going to have to focus on diseases for which there remains a poor outcome. And I think metastatic sarcoma is a great example of diseases where we haven't made any improvement in decades. Diseases for which, because they're so common, there is an unacceptable high annual mortality rate, not because the outcome hasn't improved, but because they're so common. And I think ALL is a great example of that. I think we need to also look at the burden of late effects and Hodgkin and run studies where our goal is to maintain high EFS, but to reduce some of the late effects. And I think Hodgkin lymphoma is the poster child for that. And then we need to be open to these targets of opportunities, diseases for which there are just these really exciting drugs that we could study. Larotrectinib is probably a great example of that, and it's being studied in a phase 2 study for frontline treatment in the Children's Oncology Group. What drugs will we bring forward? Well, we're going to need to have a strong preclinical rationale for a targeted agent, documented that's relevant to the malignancy, that has some preclinical activity, either alone in combination. We're going to want to see either single agent activity or a randomized study showing that this targeted agent has activity when combined with some other standard chemotherapy. And we'll need to have some feasibility and tolerability data. And that's actually where I think small consortia can help us a lot in providing feasibility and proof of concept for a lot of studies. But having said that, I think we need to recognize that empiricism probably still has a role even in 2021. This is a study published 2 years ago from the Children's Oncology Group for high-risk neuroblastoma, comparing double transplants to single transplants. And I will say that there was no preclinical model that predicted that 2 transplants would be superior to 1 transplant. There was no biomarker that allowed us to select this. There was no, I think this is something that we empirically chose to do, and yet we saw an improvement in event-free survival giving children 2 transplants compared to 1 transplant. So even in 2021, there may be a role for these empirically derived studies. There are many other studies that I think areas that we need to think about research, and those include non-chemotherapy questions such as surgery or radiation questions. We have a great opportunity to confirm or discover biomarkers and use them in risk stratification, either in clinical trials or from our biology studies. We have a gold mine of epidemiology data and access to germline material. So I think this could be the focus of future genomic analyses, looking at associations in epidemiology. With the burden of both early and late effects being paramount, I think we would be well suited to think about intervention studies that are designed to reduce symptoms, either short-term or long-term. And we also need to consider the social determinants of outcome, including medication adherence, which is being studied by the Children's Oncology Group. I think Project Everchild is a real opportunity that we have if we can invest the right resources to make this work. I think, this is our best opportunity to collect data and tissue in the absence of a clinical trial, and biobanking is really a core COG function. There, we have the largest biobank for pediatric cancer, and we need to do whatever we can to enhance the value and volume of material in the biobank. I think this is going to require evolution in Project Everchild. This will be supported in part through the Molecular Characterization Project, as well as the potential for future interactions with the Childhood Cancer Data Initiative. So that's been sort of a whirlwind through my view of the Children's Oncology Group, talking about where our successes have been, where our remaining challenges will be. I think we should be duly proud of the remarkable progress that has happened. The reduction in mortality in childhood cancer is truly remarkable. And I think this is due to cooperation, people working together in a rare cancer like pediatric cancer. I think the late effect burden of treatment and long-term survival, not just at 5 years, still remain areas for improvement. And I think the promise of targeted immunotherapy is there. We need to learn how we can expand that to more children so that we could deliver on the incredible results we've seen in selected tumors with targeted immunologic therapy. So with that, I'll stop. I want to thank you again, Charlie, for this kind invitation. I'm very honored to be invited. And I also want to thank everyone who's dialed into this virtual symposium for your commitment to pediatric cancer research.
Excellent. Fantastic, Doug. You had great attendance during your talk. So first, let me just start by saying, in addition to the great talk, happy birthday.
I want people to remember that when they come to the question session, that it is my birthday.
So we've had questions coming in. So first one comes from Gerald Zakier, who asked, I've always wondered why survivability is so much higher for childhood cancer than an adult. Is it the nature of the disease, the health of the patient, the emphasis on research? What are your thoughts?
Yes, to all of the above. I mean, I think when you start with basically healthy people, their organ function is pretty good to start with. I think that's helpful. I do think we're fortunate that so many of the tumors we treat are very sensitive to chemotherapy, as opposed to many cancers in adults. So I think that probably leads to it. I think, we have spent, the focus on understanding the biology, the focus on trying to identify the populations that need more therapy or can get by with less therapy has been a real strength. And I don't think we should underestimate the fact that we study so many children with cancer compared to adults. I mean, the percentage of adults who are participating in biobanking studies or clinical trials is so much lower. So I think despite the rarity, we are learning from as many children as possible. I think that's actually made the difference. So it's all of the above.
Fantastic. Ann Raymer asks, what's the impact been of race FDARA on drug development and access in pediatrics? Too soon to tell?
I think it's too soon to tell, but it's looking encouraging. I mean, the number I've heard from both Greg Riemann, who sees these sees the applications coming from companies who know that they have obligations under race to they're not going to get an easy waiver for pediatric cancer. The number of companies that have approached the FDA with initial pediatric development plans has gone up. I think Beth Fox could talk about this. I think certainly the traffic that's going to our developmental therapeutics committee has gone up because companies realize that they can't just get a waiver because their drug is for lung cancer. If their drug is biologically relevant potentially in pediatric cancer, they're going to have to, in order to get their approval, they're going to have to come up with a pediatric plan. And so I think that's gone up. So I think it's early days. We're not even a year into the full implementation of the RACE Act, but I think it likely is going to lead to an overall increase in interest in pediatric clinical drug development.
So a good segue to follow up, which comes from Dr. Fox. Has the RACE Act impacted how COG is interacting with pharma partners, or what has that impact been?
Yeah, I think you probably should turn on her mic and let her answer that question. She's the vice chair of the DVL committee. I think I'm relatively new at this. I mean, before becoming COG group chair, I had less interaction with pharma than I do now. I'm impressed by how much pharma really, not all, I mean, there are many different types of companies, but a number of them really value our input. A number of them realize that we can help them both to tell them that that a waiver is rational and help them with that argument with the FDA, or to say, look, if you want to do a study, this is how we should do it. And in some cases, we can do the study in partnership with you. And I think it's actually been really quite exciting that we're not begging quite so much to pharma to give us drugs. We actually there's a real incentive for them to do that with us.
Fantastic. Next one comes from Eric Buffet, who says, many thanks and happy birthday, Doug. He wants to address the issue of DIPG. Barely no survivors, a huge need from a COG perspective, one successful trial only in terms of accrual that with greater than 60%, greater than 60 patients enrolled. Has COG given up on DIPG?
I don't. We can never give up on a disease for which we've made zero progress, and which is still a very prevalent disease in pediatrics. I think the question, maybe Eric's question really is COG the right setting to do DIPG studies? And this really gets to an issue of, are there other consortia where you don't need 1,000 patients, you need 50 patients or 100 patients to answer a question, and there are now consortia, certainly in brain tumors, but also consortia for other solid tumors, where if you have a modest clinical trial goal and the outcome is so poor, you don't need a lot of follow-up. You don't need large numbers of patients. So I don't know that COG's given up, but I think there's now these competing consortia that may be able to do the studies faster than COG can do it. I mean, no one will ever accuse COG being fast, right? I mean, that's not been one of our problems. At least we're not fast at getting studies up and going. Once they get up and going, they enroll very quickly. The example of the blinatumomab relapse ALL study, that study closed ahead of schedule. Enrolled fast and actually had to be closed because of excessive activity. We may have been slow at the front end, but we're not slow at once the study opens up because of this large network. But I think DIPG may be an example where there are these competing consortia that may actually be able to do the job faster than COG can. And maybe only when we get to the point where we need a large number of patients does it make sense, or where there's, you need multiple institutions beyond what you can get in a small consortia, that would be the role for COG.
Yeah, it's great. I mean, you did a beautiful job of highlighting, small, high-tech collaborative consortia. And, this may be one of the areas that can really explore as we try and come out of an era where cure rates were going up to more challenge to identify these things, to then partner with COG to identify what is the most promising approach. We're going to continue with questions. We're at the top of the hour, so the official end now, but Doug has agreed to take questions going on, and so we're going to continue with questions. So as we increase the ability for genomic characterization at diagnosis, do you think this will impact current clinical trials? And what are the barriers beyond genomic testing to getting targeted agents to children at diagnosis in clinical trials? And how do we fix this timeline?
Yeah. So let me take the first question. I think it's, if we're thoughtful, it should absolutely inform how we do clinical trials. And one of the first ways that we're going to try to use this molecular characterization project is in a study in rhabdomyosarcoma, where we're going to try to identify a few bad actors, a small group of tumors, 15% of rhabdomyosarcoma, which have a molecular alteration which would predict bad outcome with limited therapy, and try to pull them out and treat them in a different way, and maybe decrease therapy for the patients that have that once you've pulled out the bad actors. But so that's an example where, if in order to pull this off, we have to have rapid return of results. We have to have it available to anyone who enrolls, because a rhabdo patient doesn't care whether they're seen at the family doesn't care whether they're a small institution, big institution, medium-sized institution. So to run a study like that, we need to have testing done, return of results quickly, and then use it to inform how you're allocated on the study. So I think that's an example where it probably will be informative. But what the example I gave you is not, we pulled out bad actors. We didn't identify a unique therapy for them. And that, I think, is actually the harder part. I mean, larotrectinib may be, I hope we'll forget that story. I mean, it's a great story, but it may be the exception. And if we keep looking for the next track fusion, we may not find a lot of those. And so I think the biggest challenge is not that the bigger challenge is not that we can't use molecular characterization to better our risk stratification, but what's the intervention? Do we really, will that identify an alteration which there truly is something targetable? And I think the examples where that truly has borne out are pretty limited. I mean, NTRK fusions are a great example. pH-like leukemia, those are great examples, but there aren't as many other great examples, unfortunately.
Great. So just as a note, we still have 170 folks on, so you're able to continue to ask questions. So next question is the decrease in the percent of children with newly diagnosed cancer in clinical trial enrollment, that decrease in clinical trial enrollment that you referred to, is that related to a decrease in the number of clinical trials that are available with good questions, or other factors?
Well, I won't answer whether they're good questions or not. I'll just talk about availability. That's a judgment of whether they're good questions. Now, joking aside, it's clearly related to study availability. And, when there's a difference in, for ALL, we had a much higher rate of enrollment on clinical trials in this more recent era because we had open studies. But for brain tumors or sarcomas, for gliomas, for instance, or for sarcomas, we had a much lower rate of enrollment on clinical trials because there weren't open clinical trials during much of that period of time. So it's the absence of a clinical trial, I think, rather than people being disinclined to enroll on a clinical trial. I think it's the absence of the clinical trial that is the barrier. And I'm not advocating that we go back to the era where we had an open study for every child, because I don't think that's rational. I mean, we need to have a really good question that we can answer, and we can only answer in this setting to do a clinical trial. And I think that's the bar where that really good question is pretty high. That's why I think we have to figure out a way to study the patients who are not going to go on clinical trials, because there will be biologic insights that we'll get because we have 50 high-grade glioma specimens in the bank, even though we didn't study them on a clinical trial.
Great. And maybe the next one to segue into this question is, if we think about the sarcomas, the metastatic sarcomas with no progress in terms of cure rates recently, what is the way forward for those? If we step back and look across the entire field, how do we make progress for something that we've been stalled with?
Yeah, I think this is the reason I stopped being the chair of the soft tissue sarcoma committee, because 11 years on, I didn't make any progress at all. I think I think this is going to be a tough one. I have to think there's something in the biology that we need, and we're not giving I don't think we have the right number of specimens or access to specimens for people to really study this. I mean, if you look at our bank, the number of cases where we have the diagnostic and the metastatic tumor or the recurrent tumor is so small. I mean, we really need to enhance what's available in the bank. And then I I throw it to the 175 or so people still on this call who are biologists to say, tell me what you want to study, tell me what specimens you need, and let's work together, because we've tried every chemotherapy trick that we know, and it has failed for metastatic sarcomas. We need a different approach. Maybe it'll be immunotherapy. Maybe there'll be an approach with cellular immunotherapy that'll be a difference. I don't know. We have to do something fundamentally different than what we've done so far, because what I showed you about all those improvements with empiric changes in dose and schedule and timing, that hasn't worked at all for metastatic sarcomas. We need a totally different approach.
Great. Next question comes from Jingwei Zhang about the medulloblastoma data you were showing. Was the carboplatin efficacy in group 3 medullo related to the MYC amplification status? Do you happen to know that, or any information on that?
I do not know that, but the data are available, because it was, that the beauty of that analysis was, all the specimens are there. And so I don't know the answer to that question, but there may be somebody else who is on this call who does know the answer, but it's knowable.
Great. Next one. So bringing together the survivorship data that you showed and also the neuroblastoma tandem transplant, are those patients being followed long-term to find out the long-term consequences of a double versus a single transplant?
So I guess the answer is both yes and no. Until recently, I'm not sure that with COG, certainly didn't put a lot of effort into trying to understand the late effects of high-risk neuroblastoma treatment, because we didn't have enough survivors. But now, this is one example of where metastatic tumor, of a group of metastatic tumors where there has been improvements in survival. And we really do need to start thinking about what's the impact of late effects in that population. There is a late effect study for high-risk neuroblastoma that Tara Henderson is coordinating that will try to gather that data. But I think this actually points out another issue, which is that COG, one of COG's strengths has not been embedding late effect studies in long-term follow-up into our studies. We have efforts in late effect studying, but we are not as good at tracking our patients beyond 10 years, or even up to 10 years. And I think for that, we were very dependent on independent studies of late effects, studies like St. Jude Life or CCSS, because I think that we're just not set up to follow patients that long. That's a limitation. We may have to change. If our goal really is restoring children to health for a long time, not just for 5 years, we may have to develop a strategy where we actually can follow children beyond 5 or 10 years from their original diagnosis.
Great. Next question from Amit Deshpande. How do non-academic / biopharma investigators access molecular data or access the biobank? Will the data be made publicly available?
Yeah. So there's a couple components to that. Pharma, private agencies can make requests for the biobank to COG, and we have a variety of companies that have asked us for certain types of tissues, tissue microarrays. I won't say COG is fast. That's not one of our strengths. So the request process takes a while, but we don't restrict the availability of the biologic material to academic investigators. The data, most of the data that is generated, the molecular data generated of COG studies is generally not stored at COG. It's stored by the investigators, and they may have obligations to deposit them into dbGaP or some other publicly available source. I think that it is one of our limitations that we don't have as robust a central storage of genomic data. We're very good at the specimens, but once they go out, we don't have as good a linkage of the higher dimensional genomic data. But that is, once they're deposited in publicly available sites, they can be available. And in any of our COG publications, we're required for the primary and selected secondary aims to put patient level data into the NCI data archive that could be mined by anyone, including pharma.
Great. Next question comes from Omar Chamdeen, who says, hello, amazing talk. A lot of centers around the world treat as per COG protocols, including ongoing ones. Most of these centers do not have the ability to participate in such studies because of their size and capabilities. Why not have a version of COG participation that allows centers around the world to participate according to their own abilities? This will both improve patient care at these centers and increase the number of COG patients remarkably.
Yeah. I think that this really gets to the one of these tough issues about what's the mission of COG, and mission is often driven by how we're funded. We're funded by the NCI to conduct studies within our network, and the network is pretty constrained with international sites, and that's just by design. That's how our funding runs. And that doesn't mean that there couldn't be tremendous benefit both to the international site who has that, by using COG studies, or to COG studies when we're trying to look, at rare tumors and we're trying to increase accrual. But I think the unfortunate reality is we're accountable to our funders, and our funders fund us to run studies within our network, not expanded international sites. There are some major regulatory barriers that prevent us from extending to other international sites. So I think that person is absolutely right about the value, but it's outside the scope of what COG is funded to do.
Great. Next question. So a couple times you referred to COG not being fast. Why is that, and can it be made faster?
Yeah. One of the disadvantages of cooperative group work is you got to get everybody on board, and getting consensus is hard. We also have multiple. We don't have a single funder. We have multiple funders that have requirements. So I may want to do a study, but I have to convince there's multiple steps of review to lead to that being approved. And if we're gonna the investment in these large phase 3 studies is a huge investment of time and person power, of patience. I think the NCI legitimately says, if we're going to fund something that's going to run for 6 years and treat 2,000 patients, we darn well better be sure this is a great idea, and not just a half-baked idea that you came up with on your birthday. Let's come up with something that's really good. And so I think that's led us to be slower. I think in some cases we can move quickly. I think studies that we've done in collaboration with pharma, where pharma is our partner, and we were negotiating with pharma about how the studies can go. We've done some studies very quickly with pharma, and there's some examples just in this year where we've moved incredibly quickly from development to completing the study and having a regular package ready is really quite quickly. So we can do it quickly. I think the more dance partners we include in our review, the slower we're going to be. But as I said, we're slow on the development. Once we turn the switch and the study is on, we rarely lag behind in accrual. It is rare that we have to shut a study down due to poor accrual. Once we turn the switch on, accrual usually is well ahead of schedule.
Great. So we've come to the end of the questions. I want to really thank you for agreeing to stay long. I think it's always a treat for people to be able to ask more in-depth questions and hear from you as an expert. I think you've given yourself a great challenge and opportunity to now on your birthday to go more than half-baked, Doug. And so by the time you get to sleep tonight, you can come up with your next COG trial. Thanks again for participating. I think just an ideal topic and talk for this series. And we, as a COG institution ourselves, we very much appreciate your efforts and collaboration. Thanks all.
All right. Thanks a lot. Bye-bye.